Hello, I'm John Clymer, Executive Director of the National Forum for Heart Disease and Stroke Prevention, and a member of the U.S. Community Preventive Services Task Force. The National Forum is working in collaboration with the American Heart Association and the Centers for Disease Control and Prevention to engage collaborators in the Million Hearts Initiative to reduce 1 million heart attacks and strokes by 2017. I'm joined today by Dr. Phil Huang, who's Medical Director at the Austin-Travis County Health and Human Services Department in Austin, Texas. Dr. Huang is former Bureau Chief of Chronic Disease Prevention and Control at the Texas Department of Health. And we're going to engage in a short conversation about the Community Preventive Services Task Force, its recommendations, which are compiled in a resource called the Community Guide, and how those recommendations can be put to use at the community level to reduce the burden of chronic disease. A short bio on both Dr. Huang and myself are located on the National Forum website along with this podcast. Before we begin, Dr. Huang, you've told me several times that you have a mantra, if you will, or a standard practice, so that as you and your colleagues in chronic disease prevention are looking to reduce a risk factor or to decrease the incidence of a chronic disease, you always start in one place. Where is that?
Well, you know, we really, with the limited resources that we have, it's so important that we use it in something that's evidence-based. And so really, we do always go to the community guide, see what the evidence-based recommendations for interventions are, and really try to follow that. We've actually built that into our own department's strategic plan, that evidence-based practice and best practices are what we implement.
Great. That's great. So during this podcast, we're going to talk about what is this community guide to which Dr. Huang and I are referring, and what are the recommendations in it for addressing risk factors for cardiovascular disease, and particularly the ones that are relevant to the Million Hearts Initiative. And then we'll talk about how public health practitioners can use the recommendations in the community guide to determine policies and practices that will reduce cardiovascular disease, and particularly those that apply to the risk factors covered under Million Hearts, which are called the ABCs. A standing for appropriate preventive use of aspirin, B standing for blood pressure control, C standing for cholesterol control, and S standing for smoking cessation and prevention, ABCs. We're also going to talk about how to engage partners in adopting and implementing Community Preventive Services Task Force recommendations on cardiovascular disease, and we're going to do all of this in 10 minutes. So let's begin. The Community Preventive Services Task Force is an independent, non-federal, non-compensated panel of public health and prevention experts who are appointed by the director of the CDC. The members represent a broad range of research, practice, and policy expertise in community preventive services, public health, health promotion, and disease prevention. The task force always includes members who have experience in state and local health departments and members with experience in integrated health systems. The task force seeks input from partner organizations and agencies and from individual policymakers and practitioners, such as health department staff, educators, city planners, etc., and from scientists and even from businesses and employers. Now, task force recommendations and the systematic reviews of the evidence on which they're based are compiled in the Community Guide, which one can access at www.thecommunityguide.org. Again, that's www.thecommunityguide.org. These are evidence-based recommendations. They are not mandates for compliance or for spending resources. The Community Guide really is a resource for decision makers and stakeholders who want to allocate resources effectively to protect and improve people's health, to reduce future demand for healthcare spending that's driven by preventable disease and disability, and to increase the productivity and competitiveness of the U.S. workforce. So it's an information source, a go-to source for evidence-based policies and practices that have been found to work to prevent cardiovascular disease and other diseases and the risk factors that cause them. The task force approach to cardiovascular disease is to review a wide range of intervention strategies. So these would be effective approaches to address the most common risk factors for cardiovascular disease. So things such as tobacco use, nutrition, physical activity, obesity, excessive alcohol consumption, diabetes, all of which, as you probably know, contribute to or are linked to cardiovascular disease. So today we're going to focus on just a few examples of more clinical approaches to addressing high blood pressure, high cholesterol, and smoking, the B, C, and S of the ABCs. So we'll begin with one intervention that was recently recommended by the task force following a systematic review of evidence, which means a very comprehensive examination of all of the literature, all the studies in English language done around the world related to the effectiveness or measuring the effectiveness of a particular intervention. The intervention can be a policy or a practice or a system change or a program. And in this case, in our first example, the intervention is team-based care for blood pressure control. So the task force, the Community Preventive Services Task Force, found that a health systems intervention that uses a team, so that would include primary care providers and other health professionals such as nurses or pharmacists and patients working together, working in concert, to improve blood pressure control among patients who are at risk for cardiovascular disease is highly effective. There is strong evidence that a team-based approach, team-based care, reduces blood pressure in individuals and improves blood pressure control in a larger proportion of patients. A second example is reducing patient out-of-pocket costs for medications to control high blood pressure and to control high cholesterol. So this can be done through various strategies, and often there's a role for public health agencies, a leadership role and sometimes a negotiation or policy role to help bring this about. And the task force, again based on strong evidence, recommends reducing patient out-of-pocket costs because they've been found to improve medication adherence and to lower blood pressure and cholesterol. A third intervention is using clinical decision support systems. So these would be computer-based information systems specifically aimed at cardiovascular disease prevention that are designed to assist healthcare providers in implementing clinical guidelines at the point of care. Again, based on a systematic review of evidence, the task force recommends this because it has found that using clinical decision support systems improves screening by healthcare providers for cardiovascular disease risk factors, and it improves practices for cardiovascular disease-related preventive care, clinical tests, and treatments. So strong evidence that clinical decision support systems improve the prevention of cardiovascular disease. Another intervention recommended by the task force is reducing out-of-pocket costs for evidence-based tobacco cessation treatments. Very similar to reducing out-of-pocket costs for medications that control high blood pressure and cholesterol. Reducing out-of-pocket costs has been found to increase the number of tobacco users who quit, which thereby reduces their risk of cardiovascular disease and other tobacco-related diseases and conditions. And then it follows that it also reduces the costs associated with the treatment and care of individuals who have tobacco-related diseases or tobacco-caused diseases. Yet another clinical guide recommendation or task force recommendation to prevent cardiovascular disease is using quit lines. So in this case, it would be smoking or tobacco quit lines that are available at no cost to people attempting to quit. These quit lines provide evidence-based behavioral counseling and support, sometimes along with medications or pharmacotherapy to help tobacco users quit. And we know that these make a significant difference, a substantial difference in cessation attempts and successful cessation attempts among tobacco users. So I think many of you who are listening today are aware that there are tobacco quit lines that are established in the state and often at the community level. They have their own numbers, but there's also a national number, 1-800-QUIT-NOW, through which citizens or tobacco users can access quitline services. So those are just a few of the interventions that are recommended based on significant and substantial scientific evidence that they work, and all of them are found in the community guide at www.thecommunityguide.org. So Phil, you said at the outset that you turn first and you urge your colleagues as public health practitioners to look first to the community guide to see what works. How do you do that in practice? How do you access the community guide, and how do you take its recommendations and put them into practice?
Well, certainly our staff, know about the community guide and look it up on the website, the site that you've cited. But we've actually been very fortunate with our clinical activities. As a health department, we've been partnering we have a group that is comprised of all of the indigent care providers in our community, and we actually have a medical director, sort of physician advisory board of all the medical directors at all of these clinics that work together. And so when we're looking at interventions that we want to implement as a group and share best practices, that's what we look at. And so we've actually been implementing all of these types of things, the clinical decision support systems, reducing out-of-pocket costs, and team-based care. We started out actually, and we were fortunate to receive some CDC funding under the Communities Putting Prevention to Work grant, where we received that funding just to start out with tobacco. And so we really actually used those funds to help support the indigent care clinics in some of the clinical decision support system changes, and actually funded some electronic health care record system changes, had the clinics look at their patient flow, where to put in a hard stop in the electronic health care record so that they couldn't go on in terms of working with the patient until they had assessed tobacco use at that visit. So, our goal was to make sure that every patient was assessed for tobacco use status at every visit, and then build in a system to refer them to that free tobacco cessation services, whether the quit line. We also helped support a local community cessation resource, the Seton sort of community tobacco cessation resource that's available for in-person group counseling, and built in those systems so that the electronic health records, again, without having to do much extra work, the provider could push a button and get those referrals. And so what we've then built onto that, when we were then subsequently got the Community Transformation Grant that expanded our activities beyond tobacco, we specifically took on the Million Hearts sort of initiative and have expanded the activities of some of the successes that we had with those same models into addressing the million hearts objectives of the ABCs, aspirin, blood pressure, controlled cholesterol, and then continuing to augment the smoking and tobacco use things. So, but we've actually built in some of the partners, some of that team-based care. We've worked on with a community community-based organization work group that includes representatives from things such as the University of Texas School of Pharmacy, where they've been working with their pharmacists to implement assessments of patients to try to identify those patients that might be most likely to be non-adherent to medication, taking their medication and continuing to follow up on those things, and building those systems in so that it is sort of that team-based care, and then that team-based care is also within the clinic setting, so that whether it's the nurse taking the patient back to the back of the room, that patient flow and all the systems that they implement achieve these things. So for blood pressure, it's making sure that every patient gets their blood pressure checked, which I think is one of the big successes we've always had. But then they also have a blood pressure follow-up plan, and then that the control is actually implemented also. And so, so building this in, looking at the recommendations of the community guide. We've also, with our indigent care sort of collaborative, have been using the health information exchange information and using chart audits. So this physician advisory board came up with recommendations on the chart audits to put some measurable outcomes to our performance, and we used the million hearts recommendations on some of those indicators for blood pressure control, aspirin use, cholesterol, and tobacco.
That's really helpful, Dr. Huang. Thank you. Would you say, in your experience, that using community guide recommendations makes a difference in the impact that you're able to have on the health of people in your community and state?
Absolutely. We do have limited resources in public health and to do these sort of interventions, and it's so critical to make sure that these limited resources are used in a way that can have the biggest impact. And that's where we really appreciate the review of what the evidence is, the strength of the evidence for some of these interventions, so that we know that when we're implementing these things, these are the things that will actually result in an outcome, a measurable outcome, and make a difference.
Great. So what you were describing a couple of minutes ago, Dr. Huang, sounds like it involves a lot of collaborators. It sounds like it's pretty resource intensive, but I think what I just heard you say is that using community guide recommendations that are proven to be effective, evidence-based, actually helps you to more effectively use the limited resources that you have available. Is that right?
Yes, definitely. And I think the providers, those in the clinics themselves appreciate that we can show them that this is evidence-based. I think when we're working with the actual implementation at the ground level, when they're trying to convince their clinicians that it's worth us making this change in the way we have patient flow and this extra thing in the electronic healthcare record that puts a hard stop or something, to have that backup that says this has been shown to really make a difference. And then also for us, it's important for us to build our own systems for documenting the evaluation and the impact that it can have. But again, up front, being able to show that this is an evidence-based recommendation really helps sell it.
Great. So as clinical practitioners are facing increasing pressure to improve quality of care and to be able to show measurable outcomes and improvements therein, it seems like that may open up some opportunities for public health practitioners to collaborate with those in clinical care and to provide some really valuable guidance to them. Is there a role for the community guide in helping you to do that?
Yeah, I think that between the link and the connection between public health and clinical care there are these tremendous opportunities for that. I think they haven't necessarily always identified what those the relationship is, and the public health even raising awareness in the clinical sector about the availability and the resources that we work with the community guide, I think is helpful. I was actually just at a meeting we're having a new medical school here in Austin, and the dean was talking about, there's a strong interest in the clinical area about population health, and so they're actually looking at developing a new department in that, and that partnership to have the population level impact, and in partnership with public health practitioners, I think is very important, and resources like the community guide are part of the things that we bring to the table to help in that, in moving things forward.
Well, good. Thank you for that. So, Dr. Huang, can you bottom line it for us? Can you tell us what the value of using community guide interventions is to you and your colleagues?
Yes. Again, we have so few resources, and the community guide really provides some direction. And what I also like is that it includes also the background, the findings and rationale for how the recommendations came about, and the references to the different studies and things that are important. Again, whether it's even sometimes it's having to convince or sell the importance of some of the recommendations to those of our partners in the clinical realm, I think those are helpful. But these are the interventions that really can make a difference in these important public health and population health areas. And so for cardiovascular disease prevention, we've really had some great success already with implementing some of these recommended interventions.
That's great. Thank you. I heard the head of public health in one of the largest cities in the country make the comment one time that when we're trying to make the maximum positive health impact with very limited resources available, a good starting point is the community guide, because it enables us to concentrate those resources on what we know works. So innovation is important, but when we're trying to maximize the impact of our resources to the benefit of the population we serve, we can begin by prioritizing interventions or policies, practices, environmental and systems changes that we know will work. It gives us the slam dunks as a starting point. Does that make sense to you?
Oh, I agree totally.
Well, we appreciate not only your talking with us today, Dr. Huang, but also you, the listener, for taking advantage of this podcast, for giving us your time. And now we want to share just a couple of additional resources with you. First, you've heard us refer to Million Hearts and to the ABCs, and you can get more information about the National Million Hearts campaign and the goal of preventing 1 million heart attacks and strokes nationwide by 2017, and about the ABCs and your role, your department, your agencies, your communities, your system's role in achieving that ambitious goal. All at millionhearts.hhs.gov. Again, that's at millionhearts.hhs.gov. The community guide, to which we've referred throughout this podcast, has lots of information available for the prevention of heart disease and stroke, as well as many other disease states, risk factors, and even injury. That's all readily accessible at thecommunityguide.org. www.thecommunityguide.org. I want to again thank Dr. Phil Huang from Austin, Texas, for joining us today from the Austin Travis County Health and Human Services Department. We are grateful, Dr. Huang, to you for sharing your expertise and your experience in moving the needle on the health of your fellow Texans by using and leveraging recommendations that you found in the community guide. And we hope that today's podcast is useful to you in your practice and in your mission to improve the lives of people in your own community.
Thanks. It was a pleasure to participate.